At this point, I think so, with the drugs that we have. And the reason I say that is obviously the biggest driver of asthma cost is going to be asthma exacerbations, loss of work and productivity. So we want to have drugs that would prevent you from going to the emergency room and losing work and losing productivity. That's the only way that these things would be pharmacoeconomically beneficial, right? So I think that's why, in part, the answer to that is yes. But the other piece is that none of them have been shown to, quote, cure the disease, okay? So they work, but by and large, they only work when you use them. So if we had a biologic that you could say, look, if you take this for 3 years, you're going to have a much better outcome for the next 10 years, that's different. We're not there yet. So it makes sense really to limit these to that patient population that is expending a lot on health care cost because we don't have a cure. Correct. They're not responding as well as they should to inhaled corticosteroids, and all of our other tools, long-acting beta agonists, anticholinergics, etc. And they're still having symptoms, they're still having poor quality of life, exacerbations, but they have that, quote, eosinophilic phenotype. Now, we do have drugs that are in development that may also improve patients that don't have that Th2 high or eosinophil-driven inflammation. But we have to see what happens in phase 3 trials, because we all know that sometimes they look good in early studies, but then when it gets down to it, you never know.